Good afternoon, good morning, everybody. So this first presentation is on the, as said by Vincent, on the TOURMALINE-MM2 study. If you remember, this is one of the study which built on lenalidomide and dexamethasone. So that's a large phase 3 international study of placebo-controlled of Ixazomib, lenalidomide, dexamethasone versus placebo, lenalidomide, dexamethasone in patients who are ineligible for stem cell transplantation. So the next slide shows the study design. We enrolled approximately 700 patients, transplant ineligible. Patients were randomly allocated to either placebo, lenalidomide, dexamethasone, or Ixazomib, lenalidomide, dexamethasone. After 18 cycles, the dexamethasone was discontinued, and the dose of Ixazomib and the dose of lenalidomide were reduced to Ixazomib from 4 to 3 and lenalidomide from 25 to 10. The primary endpoint was PFS as usual with all others secondary endpoints. So the next slide very briefly shows patient demographics. So the study population was very typical for an older population with myeloma. Of note, more than 40% of patients had an age over 75. We used this definition of expanded high-risk cytogenetics, including amplification 1Q, and we had about 40% of patients with high-risk cytogenetics. Otherwise, everything was quite typical and as expected, I would say. Next slide. So this next slide shows the primary endpoint. Unfortunately, the study did not meet the threshold for statistical significance in terms of PFS. The median PFS for the Ixazomib arm was 35.3 months versus 21.8 for the placebo, lenalidomide, and dexamethasone arm. So that's a 13.5 months PFS benefit in favor of the Ixazomib arm. So the hazard ratio was 0.83, and the p-value was 0.07. So this is, I would say, this is a kind of a typical study from my point of view, because you may say that the benefit was clinically significant, so moving from 22 to 35 months in terms of PFS, but it was not statistically significant. And what is also true is that the median PFS in the control arm was a little bit inferior as we had observed, for example, in the first study. So next slide. So next slide, I just kept one slide on adverse events because of time. So we had a little bit more grade 3 or more treatment emergent adverse events in the Ixazomib arm. We had also a 5 to 10% increase in treatment emergent adverse events leading to treatment discontinuation or leading to dose reductions. In terms of treatment emergent adverse events of clinical importance in the Ixazomib Lendex arm, we had more patients with diarrhea. In general, we had more patients with GI toxicity, diarrhea, but also nausea and vomiting, a little bit more rash, and we had also a little bit more thrombocytopenia in the Ixazomib arm. But in fact, nothing was really unexpected. In fact, these adverse events were in line with what was observed in other studies having Ixazomib, especially the Ixazomib, lenalidomide, and dexamethasone study, which was performed in relapsed refractory myeloma, so the MM1 study. So next slide. Next slide, is just a conclusion. So the addition of Ixazomib to lenalidomide and dexamethasone in this elderly, newly diagnosed population led to a clinically meaningful PFS benefit with a 13.5 months improvement in the median. But as I said before, it did not reach statistical significance. Next bullet point. So this was also true for time to progression. on basically many other secondary endpoints. For example, if you look at deep response, such as CR, we had 14% in the placebo arm versus 25% CR in the Ixazomib arm. Next is this. So this of note, the PFS benefit was also observed across many subgroups, including patients with high-risk cytogenetics. And for example, the median PFS for those patients with high-risk cytogenetics was 18 months in the placebo arm versus approximately 2 years, 24 months in the Ixazomib arm. Next point is just shows the toxicity and basically safety findings were very consistent with what we know from Ixazomib in other regimens and other studies. And finally, we just say that next point is the last point is that this is a feasible treatment option for some patients with transplant-ineligible. And for example, if you look at the median PFS observed with this regimen, in fact, it's quite similar to what was observed with VRD in several studies done in the elderly patients, such as the SFOX study or the endurance study, which was presented at ASCO this year. Thank you very much for your attention.